Hello, Sophie. You're muted.
I was putting my socks on. My feet are freezing. What's going on?
I'm hot. Oh, just getting ready to figure out how a presentation over screen share is going to go. You already did one.
Yeah, it wasn't that bad. That'll be fine.
It'll be good.
Yes. How was your weekend? Did you do anything fun?
I did homework.
That's good.
And we had to our golden doodle, he always needs to be put out under anesthesia if you want to really groom him. But the vet
Really?
yeah, he's really bad. But the vet gave us these anxiety pills that make him really logy. So we were grooming our dog on Saturday night for hours.
Oh, that's fun.
Yeah, how's your weekend?
It was good. Pretty uneventful.
Good.
Hi, Marissa.
Hi.
What's going on?
In order of the sign-up sheet.
Yeah. Oh, shoot. I should find that. Hi, Shayla.
Hi, so
I like your shirt.
I put on real clothes today.
I know.
Yeah,
For you.
I didn't.
I'm wearing the clothes that I slept in last night. I just changed my underwear and put a bra on.
That's good.
Wow, Martha.
I know.
That's good. Only do the bare minimum.
Yeah, there's no need to go put some real clothes on here.
This is the first day that I actually did I don't know, didn't just put a pair of sweatpants and a t-shirt on, but I still am wearing a sweatshirt.
Sophie, I present after you.
Who do I present after?
I don't know. I just looked at who I present after.
Oh, I thought you had it up. I have to close my window.
No, she has it. Dr. Kunis just shared it in the chat.
In what?
She just shared it in the chat.
What chat? Oh, the one on the top of the Moodle page?
No. Sophie, you go after Andrea and Lauren.
Oh, the chat. Oh, here it is.
Yeah.
Let me see.
All right.
Great.
Can you see my screen?
Yeah.
Okay, I'm practicing because I'm first. Sorry.
Marissa and Lauren, I was just looking at the case study groups, and it's us three and Maddie Joseph.
Perfect.
Yeah, we should. Oh goodness. Okay.
It's not due for a couple weeks.
Well, it's
Next week, I think.
What?
Yeah, we could do it this weekend, honestly, with our Australia PowerPoint and everything due on Thursday.
What? Say that again, Lauren.
We have so much stuff because we have our initial, or we have. Let's see here. Our week is a little crazy this week.
So Lauren, Shayla, how did you find that? I couldn't find that. Did she just post it?
It's on the week.
It's on Moodle.
No, week. Yeah, whatever.
I know. I was trying to find it yesterday, but I didn't know where it was.
This is the issue. We have our cognition discharge summary due Thursday. Also, our note for COG. For those of us that had the Australia presentation, I have an advisement meeting, and our final version of our neuro summary is due that day.
Isn't the COG discharge due Saturday?
No, it's due
Thursday.
Oh.
It might depend.
And don't forget, we have assessment forums this week for cognition.
But not to do anything. You just watch them, and then there's a quiz.
No,
yeah,
oh wait, never mind. I'm thinking of the wrong one.
I know.
I have my assessment on Monday.
Forum discussion for the evidence assignments. I can't remember for COG.
I hope not, because me and Anna didn't do one, and we thought of that last night, but I don't think we have to. I think it was just we put the handout on our video too, and then you guys fill out the handout as you're watching it.
Will there be
There
quizzes,
was a
or is
forum.
it just?
No, the quizzes are just for the assessments. So
I thought there were supposed to be forums for the assessment presentations.
There is.
it's in a forum, but you don't have to like answer questions.
Yeah.
But you have to do a forum
Oh.
post.
Well, no, not.
Not
I mean,
really.
you have to post it. That's it.
Yeah, it's just posting.
No,
it.
I think we have a forum post.
That was my
Associated.
understanding.
After the
There's a
assessment-
rubric posted.
Yeah.
Oh, I thought you just watch them and then you take a
It just
quiz.
says post the video format in the assessment discussion forum for that week prior to 11 a.m. And then it says write a summary. There'll be a quiz, and then where did my Zoom go? Write a summary. There'll be a quiz, and then the summary will be posted a week later.
Oh, maybe I'm thinking about the one about Marissa and Anna's video. There's a forum on that, isn't there?
I don't know.
So I
I
think there's a
I-
form for evidence, quiz for I, and
Yeah.
quiz for assessment.
We have to respond to your video.
Well, I didn't put any questions.
That's okay.
Yeah,
I don't really know.
or
I
like
think
We can
there's a
just ask
forum
her
for
when
that,
she
though.
joins us.
It didn't say to put any questions in the rubric. I just posted it and posted the handout because I thought that was your guys' way of interacting with it, was doing the handout. I don't know. Everything's confusing.
No, I don't think you needed questions with it. I think we just kind of respond.
Marissa, what time are we meeting on Tuesday with Mariana again? Or Katie?
4:30.
Or Vicky? 3:30?
4:30.
Oh, I do have it right. Okay.
Wait, I still don't see where you guys found the groups for the case study.
No, I found them the other day. Are they on this week?
No, they're not under week 10.
Week 9.
Oh.
Yeah. 9.
That's
Hey guys,
why.
Hi.
how's it going?
Good.
Where are you today? New York City or something?
What's that?
Where are you today?
Oh yeah, can anybody guess what movie my background is from?
Jaws.
Jaws.
Jaws? No,
I've
Yeah,
never
this is-
seen whatever that is.
Not Jaws?
not Jaws. Come on, guys,
I'm at a loss.
it's Sharknado.
I've never watched.
My brother
I was doing a Zoom with some friends. We were just hanging out, and we have a Sharknado inside joke. So I put a Sharknado screen on there, and I thought, well, I'll just leave it on for 426 and see what they think. You guys have never seen Sharknado?
No.
Oh, don't bother.
I think I have.
Have you?
Yeah, they made multiple because
They
it was
did, yeah, and they're terrible.
yeah.
But
Terrible.
They're so bad, they're funny. I think that's cool. So does anybody have any questions you want me to clear up? I'm sure you do.
We do. We were just talking about this. There's a forum for Marissa and Anna's presentation, right? That we have to respond in.
There is a forum, so they posted, thank you, Marissa and Anna, you guys are awesome. They posted their presentation in the forum. So then if you open up the forum, honestly, you guys watch their presentation. There is a handout for you to fill out for you to engage in the video and the presentation, and then just post by Sunday at midnight, your reactions, something that you think about the evidence, or what they were talking about, and then ask a question.
Were Anna and I supposed to have questions on the forum?
No,
Oh, okay.
no,
I'm kind of nervous. Okay.
no, oh my God.
Do
Don't be
Marissa and
nervous.
I need
By what
to
time on Sunday?
By midnight.
do Marissa and I need to post something as well or
Well,
respond
if
to
you could
anybody?
answer the questions that your friends post,
Okay.
that would be your participation. So it's sort of like if we were in class and people were asking questions.
Okay. Sounds good.
Okay.
Okay.
And the cog discharge is due Thursday.
Does that work for you guys?
Yeah.
The what?
No, somebody's saying no.
The what is due Thursday?
The discharge note for your on-campus client or your Head Start client, person, student, kid.
Friday would be better.
Friday or Saturday? Who says Friday?
I mean, why not?
Who says Saturday?
Saturday would be awesome.
Saturday! Saturday's the winner.
Thank you.
Okay. Okay.
The discharge.
Summary Saturday by midnight. Cool?
Saturday midnight?
Yep.
Got it. Thank you.
For the discharge summary, do you want us to include the home program right in there, or do you want that as like a separate document?
You can please submit it as a separate document because we will, after review and edit, send it to your on-campus people.
Okay. And there's no rubric for that, right? For the home exercise program?
No,
Or
that's
program?
just sort of encompassed in the DC summary rubric.
Did you say it's due Saturday midnight? Is that what?
Yeah.
Okay.
Let's see. Your virtual notes and plans do not need editing. I would strongly recommend, though, that you review the comments and edits from your CIs for your learning. For your virtual huddles this week, you are doing Abu. That's posted on this week, just the first 15 minutes of the video. Your virtual client of the week is Rebecca, which opened up yesterday at like 6 o'clock. Please watch all the videos for Rebecca, but not the one that's the ocular motor one. It's the one where she has the red glasses or the red filter over her glasses. They're just showing you sort of a unique specified strategy that they came up with a optometrist, I think. So not that one. I mean, you can watch it. It is really interesting, but that's not required for the note and the plan, but you can watch the other 4 videos. And again, it will be like Molly, where you will assume that those 4 videos are one treatment session. I did, based on some of your feedback on Moodle, put an occupational profile in there to give you a little bit more information about Rebecca to help you. Let me pull it up. So here is under week 10. There's Rebecca's link to her videos, and then there's an occupational profile for her. This video here, this virtual huddle video, that's Abu, that's for your clinic, your virtual huddles that you're doing with your CIs. Here's the discussion forum for this week that Marissa and Anna posted their presentation. Please post in here by Sunday your thoughts about the presentation and ask them a question. Thank you, Katie Kelly, Kayla, Shai, and Vicky for your assessment presentations that are posted under here. For this, the assessment presentation, I'll be posting some quizzes tomorrow. Don't freak out. It's like 4 questions per assessment. It's 12 questions total. Again, it's just to get you to look at the video and watch it and answer some questions about it, just to get you to engage in the material. That is, the quizzes will be open until Sunday by midnight too. So you have all week to plan that. And that's how the rest of the evidence synthesis and standardized assessments will go. They'll be asynchronous. Evidence synthesis will be a discussion forum, and then the assessment videos will be short quizzes by the end of the week. Again, if you posted the assessment video, you don't need to take the quiz for your assessment, but take the other quizzes. If you post for the evidence synthesis, please answer the questions that your friends ask of you for the discussion post. You do have a case study due next week. That I had posted in week 9. Here's the case studies. This is week 9. This is last week. There's the case studies, and there's a student assignment. Those will be due by 1 o'clock next Monday in the Dropbox. Same format, poster presentation, and then we'll just do during lab time next Monday afternoon, we'll do some breakout rooms, some discussions, sort of like we did in lab. That will be the whole lab time next week. So we'll probably have 45 minutes from, I'm imagining, between 2 and 3 for a case study discussion, and the rest of it is asynchronous, the time for you to do your discussion forums and your quizzes and all your other stuff, okay? I think that's everything I had to say. Does anybody have any other questions? Are we good? Okay, so we will start with the I presentations, and we're going to go in the order of the sign-up sheet, which I posted in the chat room. We're going to try to get them done this morning between 11 and 1, between this time. I do have the lab meeting opening up at 1:30, just in case we need a little bit of extra time if we run over and somebody needs to finish some presentations. But starting at 2 o'clock, we do have Heather Coles. It's going to be joining us from the speech department, the Nazareth speech department, and she's going to be talking to you about aphasia. And it's a really, really good lecture, and I'm really glad that she can join us. So that's our plan. And then after her lecture at 3 o'clock, we'll be done for the day, unless you have huddles this afternoon. Okay, so we will go ahead and get started with Katie telling us about cataracts and glaucoma.
Okay. Can you see my screen?
Yeah.
So Katie Kelly and I are presenting glaucoma and cataracts. And I'll be talking about glaucoma, and then Katie Kelly will talk about cataracts. And it's important to note that there is no technical name other than glaucoma. So I have some fun facts listed here. I'm just going to point out a few for the sake of time, but glaucoma is the leading cause of preventable blindness in the United States. There are at least 20 different forms of glaucoma as of 2013, which is really interesting. And glaucoma is a secondary condition of over 60 diseases and can result from injury as well. And I included a picture on here of projections for glaucoma in 2030 and 2050, and it rises significantly, which I'm still trying to figure out why, but I'll let you know. And there are at least 20 different types of glaucoma, as I stated before, so I just included 6 on here. And then the most important ones to know are open angle glaucoma, angle closure glaucoma, and congenital glaucoma. So open angle glaucoma, the drainage angle formed by the cornea and the iris is open, but the drainage canals are blocked. In angle closure glaucoma, the drainage angle is blocked or narrowed. And in congenital glaucoma, the optic nerve damage is caused by the blocked drainage canals or underlying medical conditions. And open angle glaucoma is the most common and what people are usually referring to when they say glaucoma. So I have some of the background anatomy on here, if you could just review that on your own. But I'll point out that the optic nerve is bolded, italicized, and underlined, as that's the specific part of the eye that's damaged, but the other eye structures lead to that damage. So the iris, cornea, and lens are bathed with aqueous humor produced by ciliary body, and that's moved through the drainage canals called the trabecular meshwork. The drainage area is located in the angle the drainage angle formed by the iris and the cornea, and there's an overproduction of aqueous humor or a slow drainage of aqueous humor that results in glaucoma. And so the high pressure distorts the optic nerve and damages the nerve cells. The damaged nerve cells create blind spots. Therefore, the image from the retina is not transformed to the brain. And remember, the optic nerve transmits electrical messages to the brain. And I have the optic nerve pointed out on these little illustrations so you can kind of see the optic nerve in the context of everything else. Okay, so the optic nerve damage is the cause of vision loss in all forms of glaucoma, as I stated before. The elevated eye pressure is due to a buildup of aqueous humor. The eye pressure increases due to an overproduction of fluid or impaired drainage system, causing the fluid to not flow at a normal rate. In the top picture, you can see the optic nerve's shape is distorted due to the buildup of aqueous humor and the resulting increased pressure. And in the bottom picture, you can see the drainage angle formed by the cornea and the iris, open versus closed, and the hole clogged versus blocked. So it can occur from birth to any age, but risk increases with each year of age. So the typical age range would be considered like 60 years old and up. The progression of open angle glaucoma is so gradual that you may not notice it until you're in the advanced stage. Angle closure glaucoma may occur acutely or chronically, and if it's acute, then it's a medical emergency and you must go to the emergency room. If acute glaucoma is treated early, vision may return to baseline, but if it goes untreated, blindness may occur within 2 days or less. Vision loss due to glaucoma cannot be recovered, but if glaucoma is diagnosed early enough, vision loss can be slowed or prevented. If left untreated, glaucoma will lead to progressive, permanent vision loss. And then the usual progression with vision would be unnoticeable blind spots in the field of vision, and then tunnel vision, and then blindness. And once diagnosed, the patient will typically need treatment for the rest of their life, as it'll be a lifelong illness. So there's many populations that are higher at risk, but a few that I'll point out is a family history of glaucoma, being over 60 years old, being of Asian or Japanese descent, having certain underlying medical conditions such as diabetes, heart disease, high blood pressure, and sickle cell anemia, and then being African American, as glaucoma is the most frequent cause of blindness, and their risk is actually 5 times higher than the rest of the population. And the increase in risk begins at 40 years old as opposed to 60 years old. So the overall goal of treatment is to lower intraocular pressure. And as I said before, acute angle closure glaucoma is a medical emergency. So this is kind of the order of treatment as you would receive. So the first line of treatment would usually be prescription eye drops to decrease the amount of fluid produced or improve the fluid drainage. And then you would often receive oral medications if eye drops are ineffective. There's also laser therapy, which a laser beam is used to open the clogged channels. There's a filtering surgery. There's a drainage tube surgery where a shunt is inserted. And then there's a minimally invasive glaucoma surgery. And then I also found emerging evidence on gene therapy, which is very, very cool. And then you could also have a combination of these, as I stated before. So medical management or medicine management is huge for occupational performance. Okay, so the typical progression of the impact on vision would be unnoticeable blind spots in the field of vision, loss of peripheral vision, tunnel vision, and then blindness. And then overall, there may be light sensitivity and glare, less contrast sensitivity, and impaired visual acuity. And then those blind spots are going to be unnoticeable at first because the other eye fills in the image of the blind spots. And then with acute angle closure glaucoma, that is the one that could be a medical emergency. You would experience eye pain, blurred vision, and halos around lights. Oh, and these are some of what that tunnel vision looks like. And then the impact on occupational performance really depends on the severity of glaucoma and when your glaucoma is caught. As it may progress to tunnel vision and total blindness, it will affect one's ability to participate in all occupations. So I have the occupations listed here, as you know. And a few examples that I have for ADLs and IADLs would include like feeding, kind of managing the food on your plate and seeing that contrasting colors, and then reading small print on appliances for like cooking or home management, and then kind of locating your clothes and identifying your clothes for dressing. And then I also thought about gathering items, which you really have to do for almost any occupation. And then I was also thinking about encountering bright lights in the community, which may disrupt or impact your visual acuity. And then safety in all occupations is really important here due to the visual field loss and the compromised visual acuity. And then for safety, medication management, such as eye drops or the pills that they have to take, driving, and functional mobility are really important to consider due to all those safety risks. And I think that's it. Katie Kelly?
Okay, so cataracts. There's no technical name for it either. Katie. Okay. So the symptoms, cataracts involves loss of transparency of the crystalline lens, impairing visual acuity. It's described as cloudy areas in the lens of the eye. Often people with this will experience cloudy, fuzzy, blurry, foggy, or filmy vision. They may be very sensitive to glare. Their color perception will be altered and it won't appear as bright. They may have double vision or see halos. And then during nighttime or daytime, they could have the problems with glare and sensitivity to light. And glasses and contacts aren't always the best at improving their vision. And older individuals may experience nearsightedness. So, like glaucoma, it's one of the leading causes of blindness in the United States. The exact cause has not been determined, but there are a lot of risk factors that may make someone more likely to get it. Progression is typically slow, depending on the type, and may not be detectable until the cataracts start to actually block the light. Cataracts can present in one or both eyes, but they're independent of each other, so if you get it in one eye, it doesn't mean it's gonna go to the other eye too. So it's an age-related etiology, and typically the geriatric population is more at risk, or it could be congenital, such as infections, injury, or developmental complications during pregnancy. It could be from a traumatic injury to the eye. Other medical conditions, such as diabetes, may contribute to it. If someone has a family history, they're at higher risk, or toxic substance exposure, ultraviolet exposure, radiation. Certain medications like corticosteroids or diuretics have been seen to maybe possibly cause it, and then smoking and excessive drinking. So as you can see, there's a lot of different types. I'm not going to go through each one individually, but depending on the setting, if you go into working with the older adult population, it is likely that cataracts will be a common vision impairment they have. I don't think it's necessary in our profession to know off the top of our heads all the exact different types, but it is important to be aware that there are a variety that all present in specific ways and would likely impact certain occupational activities. I think we can gather more what challenges and problems our clients are having through our occupational profile. Then you can also look up and see like the certain effects that the type they have may have on them. So the typical age range affected, as I stated earlier, it's an age-related condition. Commonly, they may start forming around the age 40, but people might not notice it yet because the light can still get through to the lens. And then around age 60 years old, it typically starts more developing the cloudy lens. So they'll see some impairments in their vision, but not too significant yet, depending on the person. It varies from person to person. Then at age 80 years old, people often have cataracts. So the part of the eye affected is the lens. The lens's job is to refract or bend light rays that enter the eye to properly align back to the retina. So cataracts develop when the lens proteins start to build up and break apart. And the areas with the protein dysfunction result in light to not pass through clearly to the retina, which causes the vision to be cloudy or hazy, or eventually lose eyesight. Cases of cataracts that have progressed may present with a whitish or gray film over the eyes too. Sorry, I don't mean to scare anyone. I thought this would wake people up on a nice Monday morning. As you can see, this individual in his right eye, the cataract is pretty significant. Cataract treatment. So it's important to get an eye exam to determine the best route of treatment. Normally it'll include like a visual acuity test, a slit lamp exam, and a retinal exam. The non-surgical route to treat this often involves prescribing glasses or contacts with a stronger lens. And some compensatory strategies include brighter lights, which I found to be a little odd because sometimes bright lights are a little sensitive for people with cataracts, but also magnifying glasses and anti-glare glasses for driving. The most common treatment for it is surgery. It's one of the most common operations in the United States. It's often recommended once cataracts start to interfere with daily activities, that's when you do surgery. So if it's not impacting someone yet, they may hold off on it, but it is a eye condition that progresses. It involves a fairly quick outpatient procedure. It usually takes less than a half hour to actually do. So the person may only be there for like an hour. They'll go home on the same day. And what it involves is the surgeon removes the natural lens and replaces it with, it's called an intraocular lens, or otherwise known as artificial lens. About 95% of the people with this surgery reported that their vision is better, and full recovery is relatively fast within a couple weeks. So the impact on occupational performance, kind of like glaucoma, it can impact all occupations. It just depends on how far along the cataracts are. So I thought that safety would be a big concern for all of these occupations, such as ADLs, like functional mobility. If someone can't see something properly, then they could be at a fall risk, or like when they're bathing and showering. If they're feeding, they might not be able to see as well. IADLs, driving is a major one for safety concern, because with the glare problems, especially at nighttime, with the car headlights, it would make it really difficult to see. Rest and sleep is impacted because that involves sleep preparation, so they might not be able to see like getting their clothes on and stuff like that. And then education involves a lot of reading and work as well. And play, leisure, and social participation could all be impacted too, depending on the activity.
I'd also just like to add really quick, I included some adaptations, modifications, and some ways to educate the client on my impact on occupational performance, which I forgot to say, but you can look at that.
Thank you, guys. I would say that glaucoma and cataracts is probably the most common vision disorder that you will come across in your careers that people are experiencing. You know, it's important, like Katie said, not that you have to know all the technical names for everything, but just to have an understanding of the impact on their vision, and then of course how that individually is impacting their, abilities to do what they want to do in their life. Did anybody have any questions about cataracts or glaucoma from the presentation? Okay, I think we have Emily and Maddie next telling us about retinopathy of prematurity.
Yep. Okay, so we had retinopathy of prematurity. So for causes and description, the blood vessels within the retina have not had the time in the womb needed to develop from the optic nerve at the back of the eye to the front of the eye. So these new blood vessels that develop begin to create a ridge between the retina and the back of the eye that has the blood vessels and the retina in the front that does not. And there are 5 total stages of progression, with the 5th stage being the most severe. So the populations that are at risk are babies weighing less than 2 pounds, 12 ounces, and or less than 31 weeks gestation. I didn't find anywhere that there were specific risk factors other than just prematurity that would increase the likelihood that a baby would get this. They typically always screen all premature babies for this and monitor it while they're in the NICU to make sure they don't develop it. And then for the age range affected, this condition only impacts premature babies, but it could reach a stage that could cause retinal detachment and permanent blindness that can be lifelong. So I included a video that shows the progression of the disease because sometimes, like when I was reading about it, I was having a lot of issues trying to completely understand what it was and how it happened. So I found this video and I thought it was really helpful, but there's no audio, so I'll just talk over the different stages. So this is showing, so this is zone 1. The retina is broken down into 3 zones of development. So in this example, the infant's blood vessels have only grown to zone 1. So the defining mark of stage 1 is a line that forms in the eye called the demarcation line, and this occurs between, in this example, zones 1 and 2. It always presents between the normal and the premature retina. So where it's developed with the blood vessels, this would be considered normal, and then where it didn't develop, it would be considered premature. Okay, and then in stage 2, the line begins to thicken and it starts to have noticeable height and width. And it's typically in the first 2 stages, stages 1 and 2, that they'll be able to resolve on their own. And I did include all of these stages down in the notes section of the PowerPoint for anyone to reference later. So you can show that that's the ridge forming. Once it gets to stage 3, the ridge begins to widen and the blood vessels begin to grow abnormally and start to grow over the ridge. And it can begin to grow towards the center of the eye. These abnormal vessels are fragile and can swell and leak, as seen here. Once it gets into stage 4, the weight of the vessels and from them growing towards the center of the eye, they begin to pull on this ridge and begins to pull the retina into the vitreous. And then finally in stage 5, as this pulling continues, the retina eventually detaches completely, and it is at stages 4 and 5 that there is the potential for permanent blindness. Okay, and now this is showing a more detailed side view. So you can see the areas of zone 1 and zone 2. So, as I said before, zone 1 is the normally developing portion of the retina. And since the blood vessels don't make it to zone 2 in development, this is the area, as well as zone 3, that are premature. And then again, this shows the demarcation line for stage 1. And then you can see it grow and develop and widen as it comes into stage 2. And then they grow onto the ridge and grow up towards the center of the eye in stage 3. And the ridge grows larger, the vessels grow abnormally on the ridge, causing it to lift, as seen here. And then in stage 5, there's the retinal detachment. Are there any questions about these 5 stages before we continue? You can just speak up because I can't see everyone. No? Okay.
Okay. So in terms of treatments for ROP, there are 2 treatments that are most common. And like Emily said, the ROP, I think it's on the next slide, 90% of cases resolve on their own without any of these treatments in a lot of premature babies, but in ones that don't, these are the 2 most common. The most common of all of them would be laser surgery, and it takes about 30 to 45 minutes to do per eye. And it's a small laser beam that scars the peripheral immature portion of the retina that you could see in that animation. The second most common would be an injection of a medication into the eye, and that medication facilitates normal growth of blood vessels and may help correct some of the damage. And that can be done on its own or in addition to laser treatment. It seemed from what I was reading that it's done a lot of times in addition. Rather than by itself. And then for the treatment of more severe cases, which is stage 4 and 5, which were at the end of that animation, where the damage is pretty severe, there's scleral buckling. The sclera is the white of the eye, and you can kind of see what's happening in the image. So basically, they place a flexible silicone band around the circumference of the eye, and it causes the white of the eye or the sclera to push in or buckle, and that pushes the torn retina closer to the outer wall of the eye, so it impacts vision less. And then there is a procedure called a vitrectomy, which is replacing the clear gel, which is in the center of the eye called the vitreous, with a saline solution, and that allows removal of some scar tissue and eases tugging on the retina, which may decrease the likelihood of retinal detachment, which would be really severe when it gets to that point. And the vitrectomy takes several hours to do. You can go to the next slide. So in terms of impact on vision, like I said, 90% of cases of ROP resolve spontaneously. Emily mentioned that that typically happens in stage 1 or 2, that they're gonna resolve on their own. Once it gets past stage 3, it's less likely that it'll resolve on its own. And in an article I read, it said 400 to 600 infants in the US become legally blind from ROP yearly. So that would be the 10% of cases that don't resolve. And then, so the impact on the vision depends on what stage they make it to, basically, so how severe the damage gets. So these first section of ocular abnormalities, those can happen in people where, well, in babies where it resolves spontaneously or it didn't. They may have got the treatments, they may have not. These are things that can develop at any point in their life. So we have nearsightedness, decreased visual acuity, strabismus, which is misalignment of the eyes. They could have a lazy eye, or anisometropia, I think it's called. And that's unequal focusing ability of the 2 eyes. So those can happen in anyone at any point. Those things might develop. And in the more severe cases, they're more likely to develop more severe ocular abnormalities. So that could include the eyes being unusually small or like sunken in. They could have increased fluid pressure within their eye, glaucoma, or cataracts, which are loss of transparency of the lens of the eye. They could have general inflammation of their eyes, And then retinal detachment would be the most severe case. You can go to the next slide. Okay, so in terms of impact on occupational performance, like Katie and Katie mentioned, these visual impairments are going to affect every occupation that you engage in. So I just listed some that I think would be particularly troubling if you were to end up with some of the visual impairments. So thinking about children, I was thinking about educational engagement. You'd have difficulty reading, possibly writing, maybe looking at things on a computer screen. Functional mobility in terms of safety, like they mentioned as well, maneuvering around their environment if they have low vision. A potential for difficulty with all of their ADLs because of low vision or visual impairments or possible blindness. And personal device care, the majority, from what I found, of these children end up having glasses at some point in their life or as adults. So that's a personal device they'd have to then manage and clean and take care of. And then driving and community mobility, which would depend on your level of vision loss, whether you could engage in those or not. And then in terms of social participation, I was thinking that since in severe cases, there's misalignment of the eyes or a lazy eye that could be pretty severe and noticeable, that might have a psychosocial impact, especially on kids. And it might have an impact on their self-confidence and the way they look. And it might impact their willingness to engage with others. You can go to the next one. So these are just some considerations I put in here. If you were working with a child who had this, they're really the same as any strategies you'd use with any child or adult with low vision. And of course, which ones you use is going to depend on how severe the visual impairment ends up being, which is how severe the damage was. So you would organize their environment in a way that's safe, minimize hazardous objects. You can suggest adaptive equipment, which would be magnifiers, lights, a lot of the stuff we talked about in our lecture last week. You could explore accessibility features on technology devices, which would be especially helpful for kids now that a lot of education is online. Not just because we're virtual now, but in general. And then you could add contrasting visual cues to an environment, which could cue them to anything like we talked about. And then adapt their classroom environment to meet their needs. They may need to move closer to the teacher, to the board. They may need enlarged fonts. So that could be something you work with their teachers on to make sure that their needs are met and that they're not falling behind academically. And that is it.
Interesting. That's it. Did anybody have any questions? Okay.
Thank you, Emily and Maddie. So when you talk about, things from the perspective of kids, right? So you're talking about like from birth, right? We're talking about premature babies and how this impacts them really from birth. And this is where I'll tell you that I have a beef with the occupational therapy practice framework in the list of the occupations. So for kids, especially premature babies from birth and on, I think one of their occupations that we should certainly recognize and that we do sort of in our practice, but we don't have it listed in our practice framework, is development, right? So one huge job of that baby is to focus on their own development. So retinopathy of prematurity, vision certainly, again, depending on the severity of the vision loss, can have a major impact on their motor development, their cognitive development, their social development, psychological development, all of those things. So I think development is a huge area that is lacking from the framework. Thanks, guys. Let's see, who's next? Andrea and Lauren for optic nerve atrophy.
Okay, excuse me. All right, I'm going to share my screen.
So we're presenting on optic nerve atrophy, like we just said.
Yeah. Oh, okay. So optic nerve atrophy is usually just abbreviated ONA, and also sometimes kind of synonymous with optic neuropathy. And it's characterized by irreversible damage to the optic nerve, and it causes vision changes or total loss, and it cannot be corrected, as irreversible implies.
So a little bit of the anatomy behind it. The optic nerve, cranial nerve 2, connects the eye directly to the brain from the retina to the primary visual cortex. And it carries the visual information that we receive by the photoreceptors in the eye to the brain to be processed and percepted. And then damage to the retinal ganglion cell axons anywhere along the path of the optic nerve leads to vision changes, and if severe enough, though rare, a complete loss of vision.
So a little about the etiology. ONA can be considered like the degeneration or the wasting away of the optic nerve, and it's a result of injury or damage, which can occur in so many different ways. Some of the main ways are that intraocular pressure from glaucoma, ischemia, lack of blood flow, like in a stroke, an infection, trauma to the nerve. There's the autoimmune or inflammatory condition of it from like MS or lupus, compression from a brain tumor. There is some genetic or hereditary versions of this, and it's not to be confused with malformation and during development of the optic nerve, but actually just you inherit this tendency for optic nerve atrophy. And then also nutritional deficiencies can cause it. So like I said, in rare cases, a congenital or hereditary cause will affect young children or young adults. And children can also experience, as we know, TBI, MS, and stroke, but it's most commonly seen in the adult population due to the nature of the diseases that cause it. And then this is just, Lauren and I were trying to really parse this all out and figure out what caused it. And I found this chart, and we thought this really shows you how complicated it really can be. You can have these primary causes. My cat wants to present with me, sorry. Primary causes that are within the body, or secondary, more trauma kind of causes. And then the glaucoma is its own beast, as we've already seen from Katie.
So the progression, it really depends, the speed of the progression and the potential for improvement or to slow it down of this visual impairment actually can point to what the potential etiology of an optic neuropathy is, or vice versa. If you know what the etiology is, then you might be able to know kind of the progression. So in patients with extensive lesions, vision loss may be progressive and occurring slowly. In patients with optic neuritis, it might evolve quickly and then subsequently improve. I thought about kind of for here the different types of MS and how there is a type that kind of progresses and then relapses. And then an ischemic optic neuropathy caused by a stroke would be a sudden loss and less likely to improve. Also, a loss caused by TBI, so it's a trauma, would obviously occur very quickly. And then it's important to know, and we'll talk about this again, that central vision tends to be affected first.
So in terms of treatment, unlike the other diseases and conditions we've talked about so far, since ONA itself is not a disease, and the damage to the nerve is irreversible, ONA can't be treated itself. And so, but progression of atrophy can be stopped or slowed if the underlying cause of the disease can be managed. So that's the only treatment. The only treatment is managing the underlying pathology. So having glaucoma treatment, having cataract surgery or whatever. And prevention is also possible in some cases through early detection. So when you go to the eye doctor and they do the little glaucoma test, that's trying to prevent long-term damage to the nerve.
So the impact on vision, the following symptoms may occur. We found varying symptoms. So we came to the conclusion that because of so many different causes, it can affect your vision in a lot of different ways, and the optic nerve carries all the visual information. So I guess it just kind of depends on how that's atrophying and being affected. So blurred vision was one of the most common ones, so just a general reduction in the sharpness and acuity of the vision. Also difficulty with peripheral vision was huge. Color vision deficits, everything kind of looks faded and not so bright. Decrease in the brightness of one eye, the eye that's the nerve is being damaged. And then an interesting one I found in a couple of different places was the loss of the constriction of the pupil to light. So kind of that pupillary reflex will start to decrease and may eventually go away. And then scotomas, like we said, central vision is most often affected. And then in rare cases, blindness. And then to kind of summarize those impacts on the vision, optic nerve atrophy causes a dimness and also reduces one's field of vision. Fine detail will be lost, colors will appear faded, and the pupil will lose its ability to retract light over time. So this image kind of in the upper right corner, it's showing the visual field deficits in patients with optic nerve atrophy. And the one labeled A, it's showing essential scotoma. And this one has been caused by inflammation, so the optic neuritis. In the second picture, B, this is essential scotoma, which is connecting to the blind spot in the eye and is in a patient with optic neuropathy due to a B12 deficiency. So this would be a nutritional deficiency cause. The image C is a superior altitudinal central scotoma, and this one is caused by a tumor pressing on the nerve. And then D is an inferior arcuate altitudinal scotoma. This one is caused by ischemia, so most likely a stroke. And then E is also ischemia. F is inferonasal step in a patient with glaucoma. So that just kind of shows you the different causes and the difference that that will present based on cause and just kind of where the loss of vision is. So you can go to the next slide.
So the impact on occupational performance, realizing we probably all have a lot of the of the similar idea here is that you need your vision for everything. So we thought, what do we want to consider in this, and what are they used to? Did they have normal vision prior? Was there other vision problems before? And also this, and I know other people have shown some pictures of, but this is like an idea of what it looks like, and it's more of just like a general blurry, faded dimness, and lack of brightness. But so with this impact on the vision, safety was the first thing we thought of as far as what could happen. ADLs and IADLs could be affected because with difficulty locating objects or reading fine print. Functional mobility may bump into things, or you might have some issues with communication, like being able to see someone's facial expression if you can tell like that the person's face is very blurry. Driving would be pretty dangerous. And then leisure, social, and work or education impacts all vary.
And then we came up with some strategies for how we may be able to help. So I kind of tried to find some pictures that demonstrated them, but providing contrast strategies, which I know we've already talked a lot about, but just an example of those would be like light food on a dark plate, emphasizing the importance of proper lighting. We've often talked about that people in their homes naturally do not have the greatest of lighting. So just really trying to provide some strategies for them, assisting them in utilizing their other senses, such as like tactile and auditory cues or strategies. Maybe if you can't really see something, kind of feeling it to figure out what it is. Removing the safety hazards in their homes, such as tripping obstacles, kind of maybe looking at the layout of their home and maybe how we could structure it differently. Using bright colors for safety, but also for toys with children so that they still are able to recognize colors, just because the optic neuropathy does cause that general dimness. And then also incorporating familiar and real objects into treatment, which is what we do anyway, but just their ability to rely on familiar tactile properties and also an easily recognizable object that they've used maybe for even years in their home and their daily lives. That was it.
Thank you, guys. Does anybody have any questions for Andrea or Lauren? So yeah, you know, like you said, you probably all are starting to see, and maybe all of you did, and we'll see as we go forward, the impact on occupational performance is it can impact everything, right? So hopefully you're getting an understanding of how important vision is, right? So, and how important it is for us to have an understanding of any visual issues that our clients have, because it really does impact everything that somebody is doing. And, you know, just to always be thinking about vision with your clients. Okay, Sophie and Rachel.
Okay, let me just pull it up quick.
Okay, I can share my screen. Okay. Macular degeneration, and we also have a tidbit on foveal hypoplasia. Can everybody hear me okay?
Yes.
So for macular degeneration, it's caused by a general deterioration of the cells of the macula, and yellow deposits can develop beneath the retina called drusen. Because the main type is age-related, it involves both genetics and environment. So risk factors include having a family history, being Caucasian, and smoking. There's also a form of MDs called Stargardt disease, which is caused by a recessive gene and appears in some young people. So these are the types. There's an atrophic and exudative type, which are more commonly referred to as dry and wet, even though that's a little gross, but that's what people say. And wet is different in the sense that instead of the macula degenerating and the cells dying off, there's development of new abnormal blood vessels that grow under the retina, which can leak and cause scarring of the retina. And it's less common but more serious. And so age-related types refer mostly to atrophic or dry. So there's early, intermediate, and late, and you don't really have noticeable vision loss until the late stage. So the part of the eye affected is the macula, which includes the fovea. And the macula is the central portion of the retina, which is responsible for focusing central vision of the eye, which is why you may still have some normal peripheral vision with this condition. So foveal hypoplasia is a different but similar presenting condition. It's a genetic condition. It's rare, in isolation, but it's commonly associated with comorbidities like albinism, achromatopsia, and other ocular disorders. And this involves underdevelopment of the macula from birth. So other characteristics include poor visual acuity, nystagmus is really common, and absent maculofoveal reflexes. And there is no treatment that's been established. Age-related MD, there are cases in 7% of people over 40, 12.5% over 60, and 33% over 80. And as I said, foveal hypoplasia is present at birth.
So as far as treatments for the age-related macular degeneration for dry, if it's caught early, nutritional therapy can help. So they put you on a diet, healthy diet with lots of antioxidants, which helps the macula. And if it's more advanced, the doctor might prescribe or have you go get additional dietary supplements. So vitamins and minerals, which support the structures of the eye cells, and the pigments. So age-related macular degeneration for the wet, laser photocoagulation. So this isn't used as much anymore, but you still might have a client that just had the older version of this surgery. So a laser is used to seal and stop the leaking blood vessels. And the newer treatment is laser photocoagulation followed by photodynamic therapy with Visidyne. So the Visidyne is given during surgery to the individual through an IV, and it's activated when the doctor uses the laser to correct the leaking blood vessels. So then it's very similar to the first one, except for the fluid through the IV. And the special laser is used to seal off the blood vessels. And this is like the gold standard. It doesn't cure it, but it can slow vision loss. And it's important to know that age-related macular degeneration is recurring, and it might require multiple treatments in order to slow vision. So because this isn't a permanent treatment, they might require these surgeries every couple years to slow the progression. In hypoplasia, there is no treatment, but I did find some evidence that the doctor might consider cataract or glaucoma surgery. But again, there's no known treatment to cure it or solve it. So for dry macular degeneration, it's more common. So this is gradual, very slow vision loss, and it's slight central vision loss. And the wet is less common, but it's severe central vision loss from the scarring from those blood vessels. So as you can see in the picture on the left, the black is what would be a blind spot. So they do have a blind spot, but they can still kind of fill the rest of the picture. Like as you can see, you can still see the little girl's face, but it's still quite blurred. And then the other one, there's like a complete loss in that central vision, and even the peripheral starts towards the end range, the peripheral vision, they start to lose that as well. You can go to the next one, Rachel. So this is just another example of the progression. So first it's normal vision, and then their vision becomes kind of distorted, which is an early symptom. And then it stops being distorted and goes back to normal, but there's a decrease in sensitivity to contrast. And then the advanced stage is that complete loss and the blind spot in the central vision. So as OTs, we could use like those visual scanning strategies we talked about last week in class, and adaptive like tools and strategies. So as far as the impact on occupational performance, it's very similar to everyone else because vision has such a big impact on people's lives. So ADLs, we were thinking like eating, dressing, functional mobility, personal device care. IADLs, childcare, driving, medication management would be a big one. Financial management, home management, meal prep, religion, shopping, and same with education, work, leisure, play, and social participation. but you can still use those adaptive strategies, the visual scanning through the peripheral vision to help compensate. Yeah, that's about it.
Thank you, guys. Does anybody have any questions about macular degeneration for Sophie or Rachel? So this is a really good example to think about when we talked about that eccentric viewing last week. So you can really see like that, that central loss of vision, right? For macular degeneration, that's a very specific scotoma. So that would, somebody like that would be a good candidate for eccentric viewing, where their peripheral vision is really where they're getting the best vision, right? So helping them find that best position of their eyes, or their preferred locus, right? To be able to get the best vision for what they're looking at. Okay, Kayla and Marissa, diabetic retinopathy.
Okay, so Kayla and I had diabetic retinopathy, which is also known as diabetic eye disease, but in most of the sources I looked at, it was called diabetic retinopathy. So this is a disease that often occurs in both eyes, and it's always the result of a diabetic complication, either from type 1 or type 2 diabetes. It's caused by increased blood sugar, which causes blockage in the small vessels that are in the retina. And as a result, the body regrows more blood vessels to try to compensate for the blockage. But these vessels tend to be abnormal, abnormal and weak, so they sometimes burst, and then that's what leads to the symptoms. And then it can be dependent on how long a person has had diabetes for, or if an individual is not taking proper care of their blood sugar levels. So this disorder is often described as occurring in 4 stages. The first stage consists of microaneurysms, which is the first sign. This is often not really noticed and doesn't cause any symptoms. And then once you get to stage 2, that's when the vessels become swollen because of the blockage. And then stage 3 is when a signal is sent for the eye to regrow new vessels. And then once you get to stage 4, that's when these abnormal vessels burst, ultimately causing the vision problems. So the disorder is often categorized by 2 different things. So if you're in stage 1 or in stage 2, you're typically diagnosed with early diabetic retinopathy. But if you're in stage 3 or stage 4, that would be called advanced diabetic retinopathy. So like mentioned earlier, the at-risk population is anybody who has diabetes, and it's either poor control, so somebody who was just diagnosed could have it if they're not taking care of it with insulin, but it's directly linked to how long somebody has had diabetes. But other medical conditions can put you more at risk, as well as smoking or a specific race. And I'm not sure if this is true now because of hearing the other presentations, but one of the sources that I looked at said that diabetes was the leading cause of new blindness in adults. But I just thought that that kind of showed how common diabetes is in general, if it has such a big impact on blindness. And then for age range, like I said, it's less age related and more diabetes related, like how long you've had it. But obviously people typically will get diagnosed with diabetes when they're older. So between the age of 20 and 74 was most common. When the disease first developed, though, almost all individuals that had type 1 diabetes developed this disorder, and over 60% of individuals with type 2 diabetes developed it. So now the numbers are not as intense, and prevention, I think, is becoming more relevant.
So the part of the eye affected, as Marissa has kind of mentioned, it's primarily the blood vessels and the retina. So the blood vessels are obviously supplying the retina with the proper nutrients and oxygen, but when they get cut off, they can't provide that anymore. And so that's when the abnormal blood vessels start to grow, because it's trying to get all the nutrients and oxygen to the retina. And so the abnormal blood vessels is called neovascularization, which since they're abnormal, they bleed into the retina and then eventually can cause retinal detachment. And then the retina, we know, is the light sensitive tissue that lines the back of the eye. And there's many layers of the retina. I believe there's 10 of them, and all including the rods, the cones, for color and vision in low lighting. And then also scar tissue can form from the abnormal blood vessels and from the leakage of all the fluid in the blood. Okay, we can go to the next. So this is just a picture I put in of what diabetic retinopathy can look like, and you can see all like the little dark spots. That's where the abnormal vessels have like burst or started to leak into the retina. So there is treatment. So prevention and control, like Marissa said, that's what they're really stressing to people with diabetes. They stress to really go get your regular eye exams so they can kind of keep track and make sure that this isn't happening. They want you to control your diabetes, your blood sugar, your blood pressure. Maintaining a healthy diet and exercise and minimize smoking can really help to prevent this disorder. And so other treatments, if it gets worse, intravitreal injections, I read, was one of the more common, and that is when they inject anti-VEGF medication, which that stands for vascular endothelial growth factor, which is what stimulates the leakage and the abnormal vessel growth. So they want to inject the anti-VEGF, which slows that down. And that helps to reduce macular swelling and slows down vision loss. And also, I read that it also helps to improve vision. And also, steroids can be injected, laser treatments that seal the blood vessels that are leaking, and that reduces the retinal swelling, and it shrinks new growing blood vessels and prevents further growth. And then vitrectomy is surgery on the retina in vitreous humor, and that removes blood and other substances to increase vision, removing scar tissue and or helping to repair retina damage or retinal detachment. And for the previous slide, when they inject the steroids, that also helps to reduce the macular swelling, which can cause the blurred vision. Okay. And so the impact on vision, typically in the beginning stages, like Marissa said, there isn't many changes in vision at first, but as the disease progresses, some begin to notice changes. They may see dark floating spots, which result from the vessels bleeding into the vitreous in later stages of the disease. They may see cobweb-like streaks, and that's also from the bleeding into the vitreous humor, and then blurred vision or double vision. And that's actually a result of diabetic macular edema, which is a secondary condition from this. And it's one of the sources I read said that approximately half the people who are diagnosed with diabetic retinopathy develop diabetic macular edema, and that's when the blood vessels leak blood and fluid into the retina, the macula swells, and then blurred vision or double vision is caused by all of the extra fluid. And then lastly, it's really a span of like decreased vision all the way to vision loss. And if another secondary complication is neovascular glaucoma, and that is where vision or vision loss, decreased vision or vision loss can occur. And then There's also the chance of tractional retina detachment, and that is when the damaged blood vessels scar the retina, and then the scars enlarge and they pull on the retina, and then it can cause it to detach, and that can result with blurred vision, partial vision loss, sudden flashes of light when looking to the side, or black floaters. And then for impact and occupational performance, like we've said, it really can impact everything. And then I listed some specifics that I thought would be important as an OT to kind of pay attention to. But the one I do want to touch on is insulin management. And I think that's really important that we find ways to help our clients manage their vision loss and adapt their everyday occupations, and really make sure that they're able to manage their insulin, because if they're not, then the vision can progress and get worse. And so I just think that's probably one of the most important for people with diabetic retinopathy. And that's it.
Good job, guys. Any questions about diabetic retinopathy?
I had one quick one.
Sure.
Kayla, are those injections you were talking about, like into the eye?
I believe so.
Okay, just wondering.
Yeah, I think it's right into the vitreous.
Yeah.
Yeah, that's what it sounded like. Okay.
But yes, Kayla, you guys are correct that, for this population, insulin management would be really a top priority, and you may, as an OT, be involved in something like that, whether it's from a cognitive standpoint or, is that a reason why, that they're having difficulty managing that, or how is their vision now impacting their ability to manage their insulin, and how is that compounding sort of their secondary impairments because of it. Yeah. Good. Thank you. Madison and Alexis for retinal detachment.
What you doing? Present. Sorry, I needed to unmute myself. There we go. Can you see it? Yes. All right, so we are retinal detachment, and this is what's kind of been coming up throughout all of the other presentations that could have an effect due to those other conditions. Oh. All right, so this is a picture of retinal detachment, and I just gave a little information about the retina, which we've definitely learned quite a few times. But when the retina is detached from the back wall of the eye, it is separated from the blood supply, so it can't function properly. Retinal detachment is considered a medical emergency. Next. So there's 3 major types of retinal detachment. Rhegmatogenous is the most common type, which is from just general aging, which the vitreous in the eye changes, and then it pulls on the retina, causing that tear. Then there's tractional, which is from diabetes, which is probably closely related to Marissa and Kayla's presentation. So the high blood sugar can cause the damage in the scar, and then as it grows, it pulls. Then exudative, which is trauma related, so leaking blood vessels or swelling in the eye leads to the injury. So that is trauma or macular degeneration or other eye disorders.
So the typical age and populations affected, we have the elderly, people with diabetes, like we said, people with extreme myopia, which is nearsightedness, and other eye disorders. And the typical ages are 40 to 70 years old, though it can be present in children, and that is most likely trauma related. So like she said, retinal detachment is considered a medical emergency. but there are many treatments for it. The goal of treatment for retinal detachment is to reattach the retina to the back wall of the eye and seal any tears or holes that may have caused the retinal detachment. So for torn retinas, you can have laser surgery, which is by an ophthalmologist, and they can make small burns around the retinal tear, and then the scar tissue will heal the retina to the underlying tissue. And then there's also freezing treatment called cryopexy, where an eye surgeon will use a probe to apply intense cold and freeze the retina to the underlying tissue. It causes the scar again that will help seal the retina to the eye. So this is the probe right here that they use. I don't know if you can see it. Can you see it?
Yes.
Okay. So yeah, that's what they use. And then for fully detached retinas, like other people have said before, there's the sclerobuccal surgery. And that's right down here. This is the silicone band that's placed outside the eye wall to push the wall of the eye closer to the retinal tear to help close it. And then it can be treated with cryopexy treatment to create the scar. The vitrectomy also was talked about, but this is 3 small incisions are made in the white part of the eye, and then they use fine instruments to operate under a microscope and remove the vitreous gel that fills the eye and drain the fluid from under the retina. And then they use the cryopexy again, or the laser, to seal the retinal tears and holes. And then the eye is filled with a gas bubble to hold the retina in place while it heals. The pneumatic retinopexy, this is where they put a gas bubble into the eye, they inject it, and the patient will maintain a specific head posture to position the gas bubble over the retinal tear. The tear itself is sealed either with the cryopexy at the time of the procedure or with the laser after the retina is reattached. And then lastly, for detached retinas, you could have just regular laser surgery. And the retinal detachment can be walled off with the laser to prevent the retinal detachment from spreading. And it's generally appropriate for more small detachments.
And so Madison's going to pull up a detachment simulator just to kind of show you what you might experience if you had retinal detachment.
Oh, did you see it? I don't know why it just went dark.
I think there's an ad up at the top.
Oh, there we go.
So I'll just kind of explain what's going on as like the symptoms as you're watching it. So it's a sudden increase in the size of floaters, which is what it begins with, and then flashes, which they don't really show, but it is possible. And then that slow shadow that comes over the vision from the peripheral, and then it can lead to blindness, which we will get to. So if it is not treated, it will cause blindness. But with those treatments, you will have a decent prognosis. Just kind of went over that while we were watching it, but this is written in words for you guys to go back and look at if you need.
So for impact on occupational performance, it's similar to everyone else's. So safety, ADLs and IADLs, especially driving, leisure and play if it's kids, and then also like work, education, functional mobility, everything everyone else said. It won't affect people for long if it's taken care of right away or as soon as possible. So the prognosis, it said that the prognosis is excellent and more than 90% of retinas are successfully reattached with 1 or more treatments, and that vision may return back to near normal. Some people still have blurred vision if the macula or the central vision is involved, but most people, they return back to near normal. And while there's such a positive prognosis for most people, it's important to utilize adaptive techniques for your clients if you do come across it in your occupation. That's it.
Thank you, guys. Any questions about retinal detachment? So this is, I don't remember if I shared this with you or not, but this happened to my mom last winter when my parents were down in Florida. So she had a full detachment, and the way she explained the progression of the symptoms is very, very much like what you guys showed, with, you know, sort of all these floaters all of a sudden, then a flash of light, and then like literally like a black curtain went over her vision, and she had like fully lost vision in her left eye. So of course, luckily, she immediately went in, and she had the pneumatic one done, and that's where they put the gas bubble in there. And so the gas bubble is supposed to pull the retina and line it back up. So she had to like lay on her left side in the couch, like staring at the floor for, I think it was 72 hours or something crazy like that. Like she could only get up to go to the bathroom, but the rest of the time she literally, so my dad had like an iPad that he set up on the floor for her to look at so she could watch something on the iPad. But luckily, like you said, it did reattach, and she did get her vision back. So it is successful if you do go in sort of emergently and get it fixed. However, there are some people that you know, continue to experience either blindness, right? Because if it doesn't get reattached, then they have a total loss of vision or some level of blurry vision after. Cool. Really, it kind of freaks you out though, this kind of surgeries and things that they do on people's eyes sometimes though, right? Like the white strap that they put around the eyeball. Yikes. Okay, Zoe and Michaela. Retinal hemorrhage from abuse.
Yes. Okay, so yeah, we had retinal hemorrhage from abuse. So it is bleeding from the blood vessel in the retina due to trauma. And hemorrhages due to abuse are most commonly seen in children. Children under the age of 3, it's typically shaken baby syndrome. Retinal hemorrhages due to abuse can be seen across the lifespan too, because obviously everyone can be abused. And it occurs with 85% of abusive head trauma cases, and it's commonly seen in child abuse and domestic abuse. And other health conditions can cause this disorder, such as autoimmune disorders and systemic vascular conditions.
Parts of the eye affected, it occurs in the retina, which is a thin layer of tissue in the back of the eye, and it just receives and converts light into signals. But I mean, it can be widespread throughout the entire retina, just depends on which vessel was affected. But when it's caused by shaken baby syndrome, which is the most common occurrence for children, it's the posterior pole that's commonly affected. But when it's head trauma, it can be preretinal, vitreous, or intraretinal or subretinal hemorrhages. But when it is abuse, it is more typical to see a bilateral hemorrhage rather than when it's trauma or anything else, it'll just be unilateral usually. And we found a statistic that says 47% of children with definite or probable abuse had retinal hemorrhage, while it's only 15% when it's just trauma. So, I mean, if you see this, it's likely that it could be used or caused by abuse. But I mean, that's a picture of the retina, so it can be anywhere throughout here, but typically with shaken baby syndrome, it's going to be towards the back.
So for progression of the condition, it usually goes away on its own. Some people don't even have any sort of vision loss or impairments. The intraretinal hemorrhage clears rapidly, whereas the preretinal hemorrhages may persist for many weeks. So even if it's still there, they might just have, in like the first slide, the redness of the eye. You want to, or the doctor wants to, monitor for tears in the retina and other possible associated complications, which are frequently seen in cases of head trauma. And laser eye surgery is used in severe cases to stop the bleeding. Not much can be done for an isolated retinal hemorrhage except for monitoring the situation and referring the patient to a retinal specialist when necessary. When there's a hemorrhage in the choroid, you want to be concerned about that, especially if it's in the macular region. It can result in scarring under the macula and loss of vision. And in most cases, there's no need to limit a patient's activities when dealing strictly with retinal hemorrhages. In cases where it moves into the preretinous or the vitreous space, doctors recommend the patient does very little activity or bending and recommend sleeping with 2 pillows in order to raise their head and allow the hemorrhage to gravitate downwards. So they want their head up so that the blood can flow down.
And then for impact on vision, there's a lot of the same type of symptoms, like the floaters or cobwebs. You could see a haze or shadows, distorted vision. And then there's also some rapid flashes of light in like the peripheral vision. There's can be some red tint, and then blurriness, and then sudden blindness is also a possibility. For occupational performance, like everyone has said, mainly safety is the biggest factor. But I mean, because it is typically in children, social participation in play is commonly affected. And like Dr. Kunish was saying, this can impact developmental progress. And then you can also, or safety is also a big factor when cooking or driving. And then self-care is also impacted, like when showering or grooming. And then psychosocial factors also play a big role in everything, just because it is caused by abuse. And which brings up a thing that we have heard before, but we don't typically focus on it, but we, as OTs, we are mandated reporters. So if we do question this, we do have to report it, and at least we should raise questions about it if we do think this is a possibility in one of our clients. But that is everything.
Good, thank you guys. Any questions about retinal hemorrhage after abuse, shaken baby? Yes, thank you for again bringing up the safety issues. Any impact on vision is safety. Yes, play. When we're talking about kids, because typically this is something that happens to the most common cases are when it happens to younger children because of abuse, and that. I appreciate the psychosocial focus, because clearly if this is a young child that is experiencing abuse, and there's going to be a lot of psychosocial issues that we need to be aware of. Good. All right, we're doing good here, guys. Let's see, Shy and Shay, cortical visual impairment.
Okay.
So we had cortical visual impairment. There is no other scientific name for it, but it's commonly abbreviated as CVI. And you might also hear people refer to it as cortical blindness. However, this is sort of misleading because people who have CVI don't always experience total blindness, even though their vision is impaired.
So for etiology, in adults, this condition can be caused by trauma or vascular insult, though it does definitely seem to be more common in children, so that's what we're going to focus on. So a lot of these causes occur during gestation, such as hypoxic ischemic injury, which is most common cause. Other causes are infections like meningitis and encephalitis, CNS malformations, hydrocephalus, trauma, stroke, tumors, and I'll talk about it more later, but there are a lot of comorbid issues that are related to the cause of this condition. So in terms of just the population, I guess, CVI is the #1 cause of visual impairment in children. And for progression, it's speculated that the majority of people's vision does improve some, and about 33% have no change and 2% have a decline. But this might be dated information because historically there is a poor prognosis, but it might not be as serious as they previously thought. But it is important to get the most accurate information about prognosis to educate parents and teachers. So the high-risk populations, sorry, I just have to find those. High-risk populations include premature birth, which is associated with low socioeconomic status. So one article actually pointed out that low socioeconomic status is a risk factor, and generally gestation complications do increase the risk because that's what causes this. And then I want to talk about some common comorbidities, which can include cognitive impairment, cerebral palsy, hearing loss, and seizures. And these comorbidities might aid in making a diagnosis. But many articles said that this condition is often overlooked and underdiagnosed. So that's just something to keep in mind.
Okay, so typical age range affected. All ages can be impacted by this, but it's usually at the beginning of end of life when CVI onset occurs. So around birth or when you have an older population who experiences like TBIs or stroke. And because it's the result of brain injury such as hypoxia and TBI, all of the ages that are impacted by CVI correspond with the ages that are associated with these types of brain injuries.
So with this condition, it's important to emphasize that there's nothing wrong with the actual eye itself. And it's all in the parts of the brain that process visual input. So in this colorful brain picture, you can see areas 17, which is the primary visual cortex, and areas 18 and 19, which are visual association areas. These are all in the occipital lobe, and it's those parts of the brain that cause the visual impairment. Nothing wrong with the eye. So we can go on to the next one.
Okay, so we have 2 slides on treatment. There's therapeutic and medical treatment. So like Shayla had said, 60% of those diagnosed with CVI show some sort of improvement in visual function. And because it's the result of a brain injury, neuroplasticity is possible. One of the medical treatments that is sort of still experimental is cerebral cooling. And this procedure is an attempt to reduce inflammation-related damage during initial brain insult. However, prevention through early identification of babies at risk for developing CVI is like the best way to go. For therapeutic treatment, conventional visual enrichment does not work for these individuals, as this tends to overwhelm them. Instead, it's best to try and simplify their environment. These children explore the world with their hands first and respond best to physical prompts. So usually sometimes they'll actually turn their heads away and touch whatever it is that they're exploring and then look at it instead of like the other way around. Consistency in what we call objects and people is very important so that they know like what it is that they're working with in their environment. And a use of a dynamic approach is necessary as severity and presence of comorbid conditions like Shayla had talked about add to the complexity of treatment. So it's not a one size fits all sort of treatment, and like we said before, it's sort of like a spectrum. So severity just depends on how much brain damage occurred during the insult. So impact on occupational performance. The spectrum of impairments result in a large range of influences on occupational performance, but like everyone had said, we use vision a lot for pretty much all ADLs and IADLs. However, areas of concern that we may work on are visual attention, object identification, visual acuity, pattern recognition, and visual discrimination. And in an article, I found that children with this condition usually display behaviors such as light gazing, photophobia, poor visual attention, color preference, restricted visual fields, atypical visual reflexes, and more.
So just to kind of bring it back to the clinical significance for OTs, awareness of this diagnosis and the possibility of having a misdiagnosed client is important, just because the visual acuity measurements and other eye-specific testing, it comes back normal unless there's something else that's causing abnormalities. So definitely dig deeper if the findings from the eye testing doesn't add up to what you're seeing in the session. You're going to want to educate parents and teachers on how to treat and do other therapy with children with this diagnosis, because things like environment do really matter. Like Shai mentioned earlier, you don't want to overstimulate, especially the visual system. And that's about it.
Thank you, guys. Any questions on CVI? So important distinction, especially if you work in pediatrics, you will work with kids that have cortical visual impairment. It is very often called cortical blindness, but it does not mean that the child is blind. It means that they have a visual impairment, and that impairment results from some kind of damage to the brain, right? And typically it's usually around birth. And yes, the environment is important, and you might be either this might be a situation where you're working very closely with a vision therapist if the child that you're working with already has the CVI diagnosis. But this also might be a situation where you are noticing things, especially if you're working in like early intervention with really young kids, that you are noticing things. Like Shai was talking about at the end, the things that you might see, like light gazing and stuff like that, you might be the one referring a child to a developmental ophthalmologist because you have concerns about their vision. So that's an important thing to remember when you're working with kids. Yeah, Anna.
What is light gazing?
Shai, do you know what light gazing is?
Is that when they just like sort of like their attention is drawn to whatever like light there is in their visual field?
Yeah. So if you see, you see that sometimes with normal visual development, like little babies, if there's a brighter light somewhere in the room, like the window or something, their gaze tends to go to where the light is. But if you see it in excess, where younger children are often the only thing that their vision is turning to is light, would be a concern, versus faces and things like that, where they're not looking at the faces and they're gazing at a brighter light. Any other questions? Awesome. Okay, Tyler and Kylie, optic nerve hypoplasia.
So optic nerve hypoplasia, which is more commonly said just like ONH, is also called de Morsier syndrome and septo-optic dysplasia. And it's a congenital disorder, which is underdevelopment of the optic nerves, either in one or both of the eyes. And depending on what type, they can also have brain pituitary problems and an abnormal hypothalamus. And these can also lead to difficulties in learning and development, and especially with the pituitary and hypothalamus, there can be hormone deficiencies, which can lead to stunted growth and development later in their life. And so there's 3 types. There's optic hypoplasia simplex, which also has 3 subtypes, which are just kind of based on like how it's presenting. So it can either be diffuse, segmental, or segmental with tilt. And then there's septo-optic dysplasia, which is type 2, and type 3 is septo-optic pituitary. And so there's not a lot of information about each one of these in particular. So we think, based on what we gathered, is just the type 1 is the most basic and has the least amount of issues, and the further up you get, there's more issues and more malformations involved. So again, like, it's not known how this occurs, but they have some research that says it might be an autosomal recessive trait because of families having multiple children affected by ONH. And so at birth, there's primary insufficiency of the retinal ganglion cell development, and that's what results in the small optic nerve head and a small optic disc. And so I don't know how well you can see it, but on the right in the picture, how they measure it is they look at the distance between the optic nerve head and then the macula. And so on the right, that's ONH, which is usually 4 discs away, whereas with normal optic discs, it's 2 to like 3 discs away. And so you can see that the macula is a lot smaller when you have ONH. And so they usually have to do clinical observations, which wouldn't be done by us. They would actually like go in and look at the eye, and the optic disc is usually small and grayish, and then again the size is a lot larger due to the small size. But overall, I think a lot of people have talked about the optic nerve so far, but it's responsible for transmitting visual information. And so the ONH doesn't just affect the nerve, but the disc itself as well, and it all kind of plays together from the underdevelopment. So it is a stable condition. It's not going to get worse as the children get older, but there are some cases where their vision does actually improve based on kind of like the intervention they get and the treatment from a young age that's going to strengthen their vision. And also that would result in a decrease in nystagmus in the people whose vision do improve. So, I mean, again, there's no cause to it, but they're starting to find links between things like maternal diabetes, alcohol use, and like infections and young maternal age, but they have no real cause for it.
So the typical age range that this disease affects, so because it's you're born with it, it's presented at birth, you have it throughout the lifespan. Because it's a congenital disorder, it affects both males and females equally, and the general prevalence of it is 1 in 10,000 in the United States. In that picture down there, you can see that it says 1.8 per 10,000, but in places like Sweden, it's 7.1 per 100,000. Oh, sorry, in the United States, it's 1.8 per 100,000. So it depends on, well, it doesn't depend on necessarily the geographic location, but in different geographic locations, there's more prevalence of it. Next slide.
He's whining at the door.
So some general treatment for this. Treatment is obviously going to be individualized per the individual. The treatment team is going to consist of often pediatricians, because we want to kind of nip this in the butt early on in development, and then ophthalmologists, neurologists, endocrinologists, and other healthcare professionals, depending on where it's being treated. And then obviously there's going to be the clinical service team, which typically consists of visual, physical therapy, occupational therapy, sometimes speech and social work as well. Generally, hormone replacement therapy was common because of the underdevelopment of the pituitary gland. So they would use hormone replacement therapy as a way to treat that aspect for the developmental deficits. The visual abnormalities were not normally treatable or at least curable, but they were able to see small improvements, like Kylie said, such as with nostalgia or nystagmus and contractions. And then continued development testing is going to be performed kind of throughout treatment, because you want to kind of take note of like those developmental milestones, as well as any intellectual deficiencies. So EI, early intervention, is going to be very popular for this population to kind of ensure that proper development is being modeled. Any deficits in refraction, and that refraction is it's a test, like a normal vision test, that determines the presence of ametropia. I don't know if I pronounced that right, but ametropia, maybe. So any deficits in refraction should be addressed only if visual acuity is at a functional level, depending on their development and age. Next slide. So continued treatment, we want to occlude the better eye to impact the visual improvement of the weaker eye. So I mean, it didn't necessarily say it like that this is used in OT, but we can kind of generalize that occluding the better eye will help improve and strengthen the weaker eye. And then we want supportive attention from low vision professionals. So again, that can be an OT professional that has the low vision certificate or certification, to help children with major bilateral vision impairment, because this can be either unilateral or bilateral. So with bilateral, we want more support from the low vision professionals. And then early visual stimulation programs normally aid in reducing the effect of a loss of vision in general growth and development. And then some other compensatory strategies that we can use could include low vision apps on your phone, low vision aids around the house. Support groups were also common, or commonly seen to be effective in individuals that have ONH. And then specifically for OT that work with this population in EI and pediatrics, we want to pay specific attention to the developmental delays in children with ONH. And they also noted specifically oral motor skill development should be addressed in early on in development to overcome any aversions to certain foods. And basically that was because they, and I think I talk about it next, but they have a sensory integration, or lots of sensory integration impairments, obviously, because their vision is affected, and vision is one of the main senses that we use day to day. So because their vision's affected, it can affect other sensations as well. And specifically for people that have developmental and intellectual disabilities. And then other areas of support that we kind of came up with based on our research, we want to obviously look at the developmental delays of children that have a dual diagnosis of autism spectrum disorder and other developmental disabilities. We want to, treat the typical visual impairments and their deficits, such as like nystagmus, contractions, the stocomas. I think that's how you say it. And then support your other professionals on the team and educate the caregivers. Next slide. So finally, the impact on vision and their occupational performance. Like I said before, sensory integration is obviously affected, and they also have limited light perception. So this will impact their engagement with the environment. So we want to support that with the patients and kind of educate their caregivers on what might be typically expected. Since the eye is one of our main senses used throughout the day, we want to kind of support that, give them the low vision aids, you know, maybe some bright colored tape for safety, because obviously the contractions of their visual field lead to functional performance deficits and a decrease in engagement and occupation. And then also the contractions of their visual field decrease their functional mobility, balance, transferring, all that stuff that's that we kind of address, so they become more of a fall risk. So that's kind of a big safety concern, as we've mentioned before throughout these presentations. So just basically some approaches that we would want to use could be education for both the client, the interprofessional team, the caregivers, compensatory and adaptation strategies, and then prevention strategies as well. And I think that's it for us. Any questions?
Thank you, guys. You know, just a good perspective there at the end about, you know, when a child is born with a visual impairment and sort of how that could, you know, spiral out into secondary issues, like issues with oral motor feeds and issues with defensiveness and issues with, you know, sensory integration and developmental skills and, you know, all those things that are really important to sort of think about. Again, when you're working with an earlier population, and specifically when there is a visual disorder involved, right? So it's not just the vision that we're looking at, right? And how does that impact, you know, sort of everything else that they're doing, especially from a developmental perspective. Thanks, guys. Okay, so it is just about time. We have two more presentations here, right? So we have retinitis pigmentosa and Hamamelis hemianopsia. So there's two things we can do. We can stop here and have the two other presentations at 1:30. Which gives us time before Heather starts to talk to us at 2 o'clock, or we can continue on and finish these last two presentations, and then I'll meet back at 2 o'clock. Anybody feel like they totally have to stop right now and need a break and want to eat, go to the bathroom? Or do you guys just want to finish them up and we'll meet back at 2 o'clock?
Let's just finish them up.
Okay, are we all good? All right, awesome. Sounds good to me.
Okay, me and Anna are next.
Yep.
I'm gonna share my screen.
My internet connection all of a sudden is it says it's unstable. So hopefully you guys can hear me and I won't exit out.
So far you sound good, Anna.
Okay, good.
Okay, retinitis pigmentosa.
Okay. So retinitis pigmentosa is a patchy disease, which means that many different parts of the eye can be affected. It affects about 1 in 4,000 people worldwide, which Vicki and I noticed might have an impact on the amount of research there is. We didn't find a ton of information, so that might be related to it being a little bit rare. So it's a mutation in one of 80 possible genes that are required for making photoreceptors. And the mutations can limit the ability of the genes to, it can limit the ability or inhibit the ability of the genes to make the photoreceptors completely. It is a genetic disorder, so there's no specific population that we found to be at risk. But it can be inherited as either autosomal recessive, autosomal dominant, or X-linked. And I have bolded autosomal dominant because that is the one that is most common. So if a parent has a dominant gene mutation, there's a 1 in 2 chance that their children will inherit the mutation in this disorder.
So for part of the eye affected, as Anna said, it's the photoreceptors in the retina, the rods and the cones. And this picture gives you an idea of what the rods and cones look like in a normal retina. And it's basically cell degeneration or cell death, I believe, of the rods and the cones in the back of the eye. The rods are most always impacted first. So because those control night vision and peripheral vision, that tends to be the first vision to go for people, because this is a slowly progressing disorder. So the cones then are more responsible for fine detail and color vision. So those deficits will come later. Also affected is the communication between the rods and the cones. So in terms of transitions from light to dark environments, people can often be like blinded temporarily if they go from one extreme to another. So it usually begins in childhood. Oftentimes, someone with RP can be legally blind by the age of 40, but the speed of degeneration and the severity differ and vary drastically. So some people go blind within 2 to 3 years of their diagnosis, so maybe by the time they're 13, and others may still have some vision at 80 years old. So like I said, you might see night blindness first, and the picture on this screen shows normal vision and what the RP looks like as your surrounding and peripheral vision starts to go and you're left with tunnel vision. And also, as stated, bright lights can be uncomfortable, and the transitions from one extreme to another can be very difficult for people.
Yeah, so I just also wanted to mention that because of all the different genes that the mutation could be on, that has a big effect on when you might experience going from blindness, or that's why so many of the people with this disorder have different experiences. So there is no known cure, but there are some interventions that are with the goal to maximize quality of life and to utilize compensatory strategies. The treatment team includes occupational therapists, orientation and mobility specialists, certified low vision therapists, and others. And the goal of therapy is mostly, like I said, to maximize quality of life for those with low vision or blindness. So they could prevent accidents and injury, like recommending lighting that would be more effective for a particular area, trying to avoid potential hazards, teaching new skills like eccentric viewing that we talked about last week, visual tracking, visual scanning, and others that can help people learn to use their remaining vision. We could try to modify the task or the environment, and that could be through recommending adapted equipment or providing low vision tools. And then lastly, a goal is to promote a healthy and satisfying lifestyle. Also, sort of a fun fact, I found that vitamin A in high doses can be shown to slow down the progression. I also read that gene therapy is sometimes used, but again, there's not really any cure, and because there are so many different genes that could be affected in this disorder, there's not really one way that works, and it's just hard to find a treatment or a way to slow the progression for everybody.
Impact on occupational performance. At the risk of, well, I don't want to repeat everything, but of course, safety, vision changes, anything with low vision is going to be the same for people with retinitis pigmentosa, recognizing faces and objects. So the social participation problems that would come with that. Awareness of the environment, where did I put my toothbrush, where's the shirt that I want, things like that. Reading, mobility, not just driving, but also walking and watching forms of entertainment. We also came across one woman who does a bunch of videos about having RP on YouTube, and she also has nystagmus. I'm not sure how often the two go together, but they were saying that nystagmus with RP would reduce her depth perception, so her ability to really know where things are in her environment and how to reach properly for something is definitely impaired. That's all.
Also, like Vicky said, there's this woman that does a bunch of videos, and we put her video in the references. She's Burke says a scientist explains my disease, and it goes back and forth between her experiences and her asking questions to this doctor and then him going through and explaining them. So if anybody's interested in learning more about how it affects somebody and then the science behind it, that's a really good video. And she also has a bunch of other videos where she talks about it, so that's there if anybody wants it.
And now's the time where I'm supposed to stop sharing, and I did it just by chance the other day. Can anyone instruct
I can do it.
Thank you.
Yep. Here we go.
Thank you.
Thank you, guys. And just see, Michaela and Blake. Homonymous hemianopsia or hemianopia, whichever one you want to say.
Okay, can everyone see it?
Yep.
Okay. Yeah, so we have homonymous hemianopia or hemianopsia. So the spelling in the evidence is kind of inconsistent, but they're the same thing. And this is a condition in which a person sees only one side, right or left, of the visual world of each eye. And it's a problem in the brain, not the eye, but it does, of course, affect vision. And then just something to remember, that the left side of the brain processes visual info from both eyes of the right side of the world, and then the right side processes the left side. So I just kind of gave examples of how that would affect that. And then symptoms may include bumping into or failing to notice things on the side of the hemianopia, frustration, tendency to turn head away from affected side, drifting away from affected side when walking, or visual hallucinations. And the pictures on the right, this was also from the Cleveland Clinic website. The top one represents normal vision and the bottom represents the hemianopia, but I wanted to point out that it's not that the person sees the black side and then the right side. That right side would just be their whole view, so they think that's the entire thing they're seeing. And kind of, if you remember from the lecture last week, Dr. Kunish included the picture that had the stop sign in it, but they couldn't see that because it was on the left or whatever side it was. So just to keep in mind. And then this is another picture that I just wanted to include. I think we've all seen this in the past, but it kind of is like a nice picture to see where it may occur. So 4 and 7 are homonymous hemianopias, and so you can see that it could be back in the occipital lobe or the optic tract. And then there's a bunch of other types, but we won't go into that. And then for etiology, the most common cause is stroke. 70% of it is due to stroke. But any other disorder that affects the brain may cause this, like tumors, inflammation, or TBI. And then for progression, chances for complete recovery is unlikely. And if any recovery occurs, it's probably going to be during that 12 to 18 month post-stroke period. And then factors to consider for progression are age, comorbidity of diabetes, high blood pressure, or other cognitive deficits. And then for age and population at risk, it may occur at any age, but the most common age range is 50 to 70 years of age. And then males are more common. And again, comorbidities at risk are diseases of the circulatory system or any neurological conditions.
So as we kind of talked about a little bit earlier, there is no part of the eye specifically that is affected. So I just kind of laid out the areas of the brain that are typically affected more generally and the percents of about how many individuals with this condition would have it affected in that area. So as you can see, it kind of can affect a lot of different areas of the brain, but most commonly the occipital lobe, and that would account for about 40% of the individuals who are experiencing this. But as we also said, the primary, I guess, effect would be the visual field cut, but like we discussed, it would be in these areas of the brain rather than specifically in one part of the eye or the other. So next one. Okay, so for treatments, like we talked about a little bit, I found it interesting that for some of the individuals that they could experience their own recovery and that it might recover on its own. And from what I found, like Michaela said earlier, the individuals that are most likely to have this resolving period are individuals who have this associated with stroke or head injury. Those are the most common diagnoses that relate to this condition that would have recovery. But like we said, full recovery is pretty unlikely. So in that case, similar to a lot of the other presentations, teaching strategies and compensation are often used, and a lot of those would involve saccades and scanning strategies, but the overall goal of treatment is to increase the visual field as much as possible. Another thing that I found some research on is the visual restoration therapy, which I included a pretty lengthy description on in the notes of the slide. So if you guys are interested in looking more into the specifics of the specific sessions and what each session would include, that's listed down below. But essentially, the visual restoration therapy goal is also trying to shift the visual field border and open it up more. And so they would have sessions of this specific therapy for around 30 to 60 minutes, and they would have them twice a day for several months is what I read, which is pretty intensive. And like I said, it's attempting to increase that visual field border, and these are the other treatment options that are sometimes used, but the most common is the teaching strategies, trying to get as much recovery as possible if it's possible, and then moving into compensation and other types of treatments would be the next step. So next slide.
And then for the impact on vision and occupational performance, I kind of separated it. So those are the visual effects, and then those are the occupational performance effects, which are very similar to all of the other presentations that everyone has done. But for a specific, I specifically found a big emphasis on driving, reading, and safety, which again, now that I've listened to the other presentations, I know are big areas of focus in a lot of the other diagnoses, but specifically when I was doing research for this, those were very common because, of course, with those visual field cuts, you are not able to see maybe some of the page or some of the areas in your home for functional mobility and such. And of course, with driving, that would definitely impact safety. So pretty much all ADLs and ADLs are impacted. Working status is also impacted. And I also found psychological and emotional effects in some of my research as well, because you are no longer able to participate in your work or leisure activities that you once used to. So that would impact possibly self-isolation, depression, and other emotional effects from not being able to participate in your typical activities. And of course, community mobility could also be impacted, and you might not be able to get where you want. I know that there was some research done on disorientation. You would bump into objects, you're unable to detect hazards, you have an increased fall risk, and you have trouble crossing the street in traffic due to the visual field cuts and not being able to see where cars are and things like that. And then just the visual effects and the impacts would obviously be the biggest: the visual field, saccades, distorted sight, double vision, decreased night vision. I did find some information on visual hallucinations and difficulty understanding what you're seeing. And I would assume that the difficulty with understanding what you're seeing comes from the fact that you wouldn't really be able to see the full image, but you wouldn't really comprehend that you weren't seeing the full image. So you might have difficulty understanding what it is. And then dimmed, and you would also move your body or head away from the affected side. I think that's it.
Yep. Good job, guys. Any questions on homonymous hemianopia or hemianopsia? So pay particular attention to the picture that they included with the visual tract that shows you, the tract from the eye into where it ends up on the side of the brain, and where along that tract, if you have some kind of deficit or impairment or injury, and how that manifests, right, to the impact on the vision, right? So homonymous hemianopia ends up after the visual tract crosses, right? And that's why you have a loss of a visual field on the temporal side. Like, let's say somebody had a stroke on the right side, and they might have a loss of it on the temporal side of the left eye, and a loss of the nasal side on the right eye. Okay, so if you look back at the visual tract, it will show you why that ends up that way. Okay, and this, again, thank you for saying that the people don't know that they're missing that part. Like when you see the examples of hemianopia, and it shows like one side is black, but that's not actually what people are seeing. They're seeing their full visual field is just the right side of that visual picture. So these are the people that saying look to the left, look to the left, look to the left doesn't mean anything to them, right? Because they are seeing everything in their visual field. So that's where you have to use visual anchors, right? Where you have to use scanning techniques, where you have to use, like that video we watched with the OT that was working with the gentleman, where he was sort of reaching around the table and things, more physical cues and things like that, because just telling people to look to the left doesn't work. Okay? All right, so what I want to say now is you guys are amazing. Amazing people. I can't believe what you can get done, like remotely, working virtually in the middle of a pandemic. I'm just astounded how awesome you guys are. So fantastic job. And go eat some lunch and go to the bathroom and all that kind of stuff. And I'll see you at 2 o'clock.
Thank you.
Bye, guys.